Dear colleagues and friends, I would like to thank Professor Fisch and my friend Sanchi Kulkarni for giving me the opportunity to present at the Oriental International Forum and ISORO joint meeting. In the following, I will share with you our experience with functional reconstruction for complications of prostate surgery. Here are my disclosures. Complications may occur after surgery for prostate hyperplasia or after radical prostatectomy. Bladder neck stenosis is a common complication after BPH treatment, whereas after radical prostatectomy, the stenosis usually occurs at the anastomosis. Urethral strictures may develop after both treatment, however, are more common after BPH treatment, whereas rectourethral fistula and incontinence are more common after prostate cancer therapy. Even though these three entities have a different etiology, incidence, and treatment, data are often combined in publications, thus interpretation is difficult. This slide is an overview on the incidence of urethral stricture and bladder neck stenosis for different treatment modalities for BPH. I have highlighted the highest incidence in red. To summarize the slide, you may expect a stricture and a bladder neck stenosis up to 10%, and there are some risk factors as low prostate weight, extensive resection of the bladder neck, large resection loop, and small intraurethral adenoma. These are radical prostatectomy series. As you can see, the incidence of anastomotic stenosis is anywhere in between 0.2 to 26%. There is a decrease of incidence over time. So in contemporary series, it's anywhere in between 0.2 to 3.6%. Open radical prostatectomy causes more often anastomotic stenosis than robotic, and there are patient-related and surgery-related risk factors. There are a couple of therapeutic options for both bladder neck stenosis and anastomotic stenosis, as clean intermittent self-catheterization, urethral dilation or balloon dilation, cold knife or laser incision, any type of resection, injections, and urethral stents. When it comes to reconstruction, the operative procedure differs. In the following, I'd like to focus on the resection and the reconstruction, as we have some data on these two treatment options. This is our experience with transurethral resection in 103 patients. We built it two groups, one after radical prostatectomy and one after BPH treatment, and you will see that there is a difference between those two groups. In the radical prostatectomy group, 30.2% had additional irradiation compared to 6.1% in the BPH group. When it comes to success, the rate was much lower with 38.4% in the radical prostatectomy group compared to the BPH group. In contrast, de novo incontinence was much higher after radical prostatectomy compared to the BPH group. Here our treatment algorithm for bladder neck stenosis. So we perform a transurethral resection at a maximum of 3 times. Then we would switch to an open surgery using the T-plasty through an abdominal approach. Should the patient be incontinent, then a secondary implantation of an artificial sphincter is performed after 3 months. There is an exception. These are irradiated patients because they have a high incidence of complications and a low incidence of success. So in those patients, we would recommend either a suprapubic cystostomy or a Mitrofanov with or without bladder augmentation or a urinary diversion. Here the algorithm for the treatment of anastomotic stricture after radical prostatectomy. As a first step, we offer transurethral resection. However, in a patient like this with a long obliterative stricture, we would immediately go ahead and do open surgery. For open surgery, we use a perineal approach and do an open stricture resection and reanastomosis. If the patient is incontinent after surgery, then we offer a secondary implantation of an artificial urinary sphincter. Also in this collective, irradiated patients are an exception. We do not offer this reconstructive treatment for the reasons already discussed in the group of BPH. What are our results? Here the results of the T-plasty. We just updated and have not yet published the data. We have now experience with 48 patients and a mean follow-up of 67 months. Success rates are with 94% excellent and the incontinence rate is 37%. These are our results with respect to open reanastomosis. The success rate was 87%, but you see that the incontinence rate is much higher than in the other collective. At least almost 74% needed a secondary implantation of an artificial urinary sphincter. However, one has to respect that the majority of these patients had already some form of incontinence preoperatively. Recently, there were some publications on Da Vinci-assisted surgery for a reconstruction of the so-called posterior urethral stenosis. They claim to have better continence rate when compared to open surgery. Be careful with the interpretation of data, as they mainly focus on bladder neck stenosis, but compare their results with those obtained after open reconstruction of anastomotic strictures. As I have shown you, these are different entities and the outcome of surgery is different. Let's switch to urethral strictures. The incidence of various treatments for prostate cancer is anywhere in between 1.1 to 8.4% and is described to be highest after the combination of radical prostatectomy and external beam radiation. For radical prostatectomy alone, there are almost no data, as reports include anastomotic strictures, and as you may see here, it's often not to distinguish. This is a stricture at the anastomosis reaching down into the bulbar urethra. Let's have a look from a different angle, and these are the data of a European tertiary center for urethral reconstruction. Nowadays, almost 40% of the strictures are iatrogenic. TUR surgery contributes with 23.6% to these strictures, whereas the incidence of strictures after treatment for prostate cancer is with 2.7% low. As one would expect after BPH treatment, the strictures mainly occur at the bulbar urethra. After treatment for prostate cancer, as we have already learned, mainly in the posterior urethra. What are the therapeutic options? If the patient is continent and the stricture is close to the external sphincter, self-catheterization may be indicated. For short primary strictures, an endoscopic intervention can be offered, either as a dilation or internal urethrotomy. Drug-diluting balloons might be an alternative, however, long-term data are still missing. For recurrent strictures or long primary strictures, open reconstruction is indicated. The non-transecting anastomotic urethroplasty was described for only very short strictures. I would not recommend stricture excision and primary anastomosis after radical prostatectomy because the patients already had an anastomosis at this level. If you do a second anastomosis down here, you leave the segment in between at risk with respect to the blood supply. Flap reconstructions require an extensive mobilization and nowadays are no longer performed in a bulbar urethra. I like to focus on the buccal mucosa graft urethroplasty, which nowadays mainly is used for this type of stricture. When it is used in the bulbar urethra as a ventral onlay, it requires minimal mobilization. However, as a free graft needs a well-vascularized bed. Here our data with 534 one-staged anterior urethroplasty, and you see the Kaplan-Meier analysis. When the buccal mucosa was performed as an initial procedure, the success rate was 87.4%. Interestingly, when we performed a buccal mucosa urethroplasty again in those patients who already had one, the success rates were similar. However, if the patient had any other type of urethroplasty previously performed, then the success rate dropped to 70.6%. The success rate of the same technique used for radiation-induced urethral strictures are worse. You see a success rate of only 67%. Incontinence was high, and you see that the severe incontinence was in 48% of the patient after radical prostatectomy and in 20% after TURP. The incidence of rectourethral fistula after radical prostatectomy is low, at a maximum 1%. It's higher after brachytherapy. Today, more than 50% of the fistulas we see are radiation-induced. Thus, we treat more complex cases. Method of choice for the therapy is fistula closure, either through abdominal, perineal, or combined approach. Rectal surgeons prefer the transanorectal or perianal rectal approach. Especially in patients with prior radiotherapy or with a complex fistula, interposition of either gracilis or omentum is mandatory. Some patients may require an additional salvage prostatectomy, and some will end in a urinary diversion. This is a nice review with 26 articles included and 460 patients. 40% had any form of pelvic irradiation and/or ablation. The preferred surgical approach was the transperineal incision, especially at high-volume centers. For tissue interposition, mainly the gracilis muscle was used. The success rate was with 87.5% high, and there was no difference in between non-irradiated and irradiated patients. But in the irradiated group, 42.5% remained on a urinary diversion and 25% on a fecal diversion. Our own data also showed a high success rate of 93%. This is a multi-institutional study with 225 patients. Two groups were built, a radical prostatectomy group versus an energy ablation group. In this series, only 3.3% remained on a permanent urinary diversion, however, 73.8% on a bowel diversion. Success rates were higher after radical prostatectomy compared to the ablation group. Complications were lower, and also the postoperative incontinence was lower. Let's move to the last complication, incontinence. If continence is defined as no pad after 12 months, then 6.3 to 52% of patients after radical prostatectomy are incontinent. In a recent publication, the risk for incontinence was highest in the minimal invasive group compared to open radical prostatectomy. However, this is due to the fact that laparoscopic radical prostatectomy was worse and perineal radical prostatectomy was best. Incontinence after BPH treatment is 3 to 9% after open surgery, around 2% after TURP, and 4.9 to 12.5% after holmium laser enucleation. However, a recent meta-analysis could not find any significant difference between procedures. I will focus on a surgical treatment and will present the recommendations of the report from the 6th International Consultation on Incontinence. Urethral bulking agents should only be offered when more effective treatments are contraindicated. With respect to adjustable balloons or PROACT, the potential benefits should be weighed against a need for refilling in peri- and post-operative complications, and longer follow-up is needed. I like to focus a little bit more in the following on the male slings and the artificial urinary sphincter. Let's start with the slings. This is a recent review and meta-analysis, and you see the bad quality of the data. Only 64 out of 833 studies could be included. The majority of papers, 76.4%, were on fixed slings. The objective cure rate had a wide range from 8.3 to 87%, underlying the bad quality of data. Adjustable slings were used in 23.6%, and again a wide range of objective cure from 70 to 92%. Chronic pain was slightly higher after adjustable slings. The conclusion of the group was that fixed and adjustable slings are an effective treatment option in mild to moderate post-prostatectomy incontinence. Adjustable slings might have higher objective cure rates, but higher complications and explantation rates. However, there is a significant heterogeneity of data. And this is in accordance with the recommendation of the 6th International Consultation on Incontinence. They also see in mild to moderate degrees of stress urinary incontinence the male sling as a viable alternative, provided that patients have not failed previous ROS surgery, radiation treatment, and have a normal bladder contractility. The latter, as well as patients with a severe incontinence, have a clear indication for the implantation of an artificial urinary sphincter. The ROS has the largest body of evidence reporting long-term success. However, the success rate and high patient satisfaction have to outweigh the need for revisions. One has to expect a reintervention in 26%, and the main reason is erosion and infection. However, continence data are good, and you see that the range is much smaller compared to the slings. 79% need at a maximum 1 pad in 24 hours. So this is the end of my presentation, and I would like to thank you for your attention.